Okay, eyelid ptosis. As injectors, when we're injecting the upper face, eyelid ptosis is really our worst nightmare of all the complications that could happen as a result of treating the upper face with toxin. Yes, it really is disastrous, really, for our patients. Really, up until this point, management of lid ptosis has really been about using eye drops in order to improve the position of the lid, but never really achieve complete resolution outside of helping in the meantime until the effect of the toxin just wears off, usually beyond 6 to 8 weeks or so. And classically, over the years we've used apoclonidine, so 0.5% apoclonidine drops applied up to 4 times a day to the affected eye, and that gave a degree of improvement in terms of the lid position, somewhere between 1 in maybe up to 2 millimeters, depending on the study that you read. So I wanted to sort of have a look at a paper that was actually published in March, which looked at a novel approach really to the management of lid ptosis, combining 2 things. Another eye drop called Oxymetazoline. So Oxymetazoline is an eye drop which can be used to improve the position of the lid in a very similar way to apoclonidine. So both are alpha-2 adrenoceptor agonists, so both will have an effect on Mueller's muscle, or the superior tarsal muscle, in order to elevate the position of the lid. So this particular study looked at combining oxymetazoline and the use of what's called pre-tarsal toxin use. So this is where, kind of ironically, we're using toxin right on the lid in terms of its injection point in order to improve the position of the lid whenever a ptosis has occurred. And so it's important that we kind of deep dive into the anatomy here and really try and get a feel for, if this happens, making sure that we get it right. So when we think about the anatomy of the lid, I'm thinking particularly about muscle anatomy, we have to think in terms of elevators and depressors, and then layers. So when we think about the muscles which keep our eyelids in a normal position when we're awake, it's really a combination of both levator palpebrae superioris and Mueller's muscle, or the superior tarsal muscle, which keep the lid in a normal position when we're awake. And when we inadvertently have an effect on these muscles with toxin, it can change this resting position and give us a lid ptosis as we know it. Now, from an anatomical perspective, the superior tarsal muscle, or Mueller's muscle, and levator palpebrae superioris both lie deep to orbicularis oculi, which is the most superficial layer of muscle when we think about the region of skin or the region of tissue which is on top of the upper eyelid. So the principle of using toxin in the pre-tarsal region, the upper pre-tarsal region, is that we inject product extremely superficially at a very low dose in order to have an effect on orbicularis oculi in this area. So if we take it that levator palpebrae superioris and the superior tarsal muscle are elevators of the lid, we know that orbicularis oculi is a depressor. It allows us to control the aperture of the eye voluntarily. So the principle of injecting very superficially into the region just above the lid line, the upper lid line, to affect orbicularis oculi is to change this dynamic such that by having an effect on a muscle depressor with toxin, we can improve the resting lid position such that the lid is more in an upper position and looks more normal. And when if you look at this study and you look at the cases that they've treated, they've been able to achieve an improvement in the lid position of upwards of 4 millimeters, which is a tremendous achievement and is much better than what we've been able to achieve in the past with drops alone. So, and interestingly, when we look at oxymetazoline, yes, it's an alpha-2 adrenal receptor agonist, will have an effect on the superior tarsal muscle. And you might reasonably ask, well, you know, oxymetazoline, aproclonidine, is one better than the other? I think probably not. And the other practical issue with oxymetazoline is it is not readily available in the UK. It is readily available in the States, but not in the UK. So for me, you know, combining aproclonidine with the use of pre-tarsal toxin is really going to be our mainstay of management now when we think about the treatment of lid ptosis going forward. So when it comes to actually injecting in the upper pre-tarsal region, the idea is that we're working on the basis that levator palpebrae superioris is inserting onto the lid, or the region of the lid, in the midline. So the principle of this approach is to actually avoid these superficial injections into orbicularis oculi in the midline and concentrate our dose and our injections both medially and laterally to levator palpebrae, such that we avoid inadvertent effect on levator palpebrae, which would obviously worsen the situation. So gotta be superficial, gotta avoid the midline. And when we look at the study and the results that they've achieved, this really looks like a nice novel treatment going forward for the management of lid ptosis. I hope you enjoyed this content. If you did, hit like, subscribe and share to see a bit more.